I'm here today with Dr. Michael Frazis. He is a general dentist in Australia and one of the RIPE Global educators. We're very happy to have him here because he's one of the rising stars around the educational circles. I've seen all of your videos and we played some of them. You're in our group as well.
Yeah, well, thank you. Well, thank you for having me.
That's awesome. And when I saw some of your videos, I asked you, hey, could you do a couple of lectures for us regarding composites? Because, composite is a mystery, right? Every dentist wants to get better at doing this. So let's jump into it. And you've got this predictable composites. Which one are you going to start first, posterior or anterior?
So I'm going to start with posterior, and I'll explain the reason why when we sort of started. But I think it's going to be self-explanatory. So I'll try to make it as fun as I can, because obviously dentistry for some people can be just a job, a chore. For other people, it's a passion. I'll try to sort of at least speak to both camps of people and help them do the best dentistry they can, no matter where they are.
Excellent.
Beautiful. All right, so let's get started. So we're talking about posterior composites, or composites, as people over in America say. So the reason why I like to start with the posterior is the same reason that we start with posterior in the restorative program. So all of the fundamental ways that we do our restorations are the same if you're working on back teeth or if you're working on front teeth. The etching is fairly similar, the bonding is similar, the cleaning is similar, the placement is fairly similar. The things that differ are going to be aesthetics, occlusion, anatomy, and a couple of other micro little bits and pieces that we're not going to go into too much detail in these two parts of the lecture. But it's super important to get the fundamentals correct in the posterior, so that when you transition over to the anterior, you know all of the parts that you need to learn and work on. You know how to place a composite properly. You know how to bond. You know that if something falls apart, it's not because your bonding system has failed. It's because maybe the occlusion isn't right, or you haven't done something, you haven't looked at the opposing arch and realized that the patient actually has an interference in a lateral excursive pattern with one of the lower incisors clipping the upper central. And so these are new problems to introduce as you're learning anterior composites that don't really make a huge difference in the posterior section. So when you learn the fundamentals of bonding in posterior, you can easily transfer it over to the anterior section from there. All right. Me and many other dentists in the world are lazy. So we all humans tend to be lazy in various different aspects. We like to do our dentistry as simply as possible so we can do it once. We don't want to have to do something over and over again. The worst thing that you can happen to you as a dentist is you do a restoration for a patient, you see them, you're like, that was difficult, I don't want to have to do that again. The patient comes back 2 days later and say, hey, my filling fell out. And you're like, oh, you have a look, and you're like, oh, it is my filling that fell out. Something went wrong. You don't want that to happen to your patients, both from a financial point of view, because then you have to redo things at your own cost because it's a day or two later. But also, it was difficult enough the first time, and the expectation the patient had the first time you did it. Imagine the expectation they had the second time, because you've actually lowered the expectation that they have of you as a dentist, rather than what you should be doing is the opposite of, lowering the expectation and then exceeding it. You lowered, they had a high expectation of you before, and then you actually lowered it. And so you've come in now at sort of a different sort of level than you had before. So the power play is a little bit different. So if you do it right the first time, even if it takes you slightly longer to do it right the first time, it's better for you, better for your patient, and better financially, because you don't actually have to redo things over and over again. And sometimes the redoing things is not 1 week later, it's a year later, or 2 or 3 years later. It's not uncommon these days for patients to go to a dentist down the road, then come to see you after a few years and tell you, well, I've gotten this filling replaced like clockwork every 1 or 2 years. That seems to be quite normal. And you go, well, that's a bit strange, because a lot of the restorations that I've placed have been in patients' mouths for 5, 6, 7, 10 years. So you start to think, okay, it's not normal for restorations to need to be replaced that frequently. Is there something wrong with the patient, the way that they're chewing, the way that they're eating? Is it a lot of secondary decay that they're getting? Or is the previous dentist, or in some cases you yourself as a dentist, doing something that's making the restoration fail sooner than it's supposed to? So if you're doing it right the first time, they last for far longer than you expect them to, which is kind of what we want. And the same goes for doing crowns. The same goes for doing veneers. We want to tell the patient, hey, you might need to replace it after 5, 10 years, but it doesn't necessarily mean that they have to replace it at that point in time. So there was a study out of a Japanese journal way back in 2011, if anyone can remember that far back, that was both a prospective and a retrospective study. And basically what they looked at was composite restorations and how long they actually would last for in ideal conditions. So it was based on survival data of the composite resins in human mouths. So they weren't on dogs, they weren't on monkeys. They were placed in a university setting. I believe it was with students, and they just tracked them for 10 years and just saw how many would actually last for that amount of time. So they found that things lasted up to 60% of the time. The restorations were there 10 years later. Now, this is survival data, so that's a lot different to then it being pristine and perfect. We're talking, it's got some margin ditching, it's got some staining around the margin, it's probably worn at this point in time. They did notice that there were some restorations that failed more frequently than others, such as non-carious lesions on the buccal cervical of teeth. They failed a little bit more frequently than others. But in general, the majority of the teeth were lasting for up to 60% of the time, that 10-year mark. So this is just showing you that if you've got a restoration that's only lasting 1 or 2 years, it might be that you just need to go back and just revisit those fundamental things about posterior dentistry that just gets things to last for as long as possible, because they can last for as long as possible. Obviously, we know that things like gold, ceramic will last longer than resin, but if it's something that's very small, we know that resin works very, very well. So there is a study that Michael Melgers and his wife Janine did way, way back in the day. I've chased him up about it many times to give me the table of data to put in. I'm sure one of these days he'll eventually give it to me. I do lecture with him from time to time, so eventually I will get the table and put it on this slide. But until then, you just have to get my mind's summary of it. But essentially what he found was the general moisture, ambient moisture in the mouth affected. There were other studies that have been done that suggest that the ambient moisture in the mouth can affect placement of composite restorations and how long that things last for. Placing a composite restoration without any moisture control, obviously, is kind of one of the worst things that you can do. Having moisture control in the form of rubber dam, constant suction using an isolite or one of those kind of systems brings the moisture level down so that you can get the best possible result. Obviously, if you're using one of those kind of constant suction devices, you just place it in and then you proceed as per normal. There are other benefits to using rubber dam, which is kind of why I'm going to focus a little bit on it now. You kind of need to learn a little bit more about it, whereas one of those other systems, you just continue with what you're doing, you just add that system in there. If you don't want to spend the money, what I do sometimes, if there is a particular case that's going to be a bit tricky to use rubber dam, I'll just have my nurse hold the low volume suction in the general area just to bring down the moisture of the ambient environment so that there isn't that sort of moisture content in the air that's going to cause that restoration to increase the amount of staining that it has over time. Because one of the fundamental reasons that the restoration gets replaced most times is the patient changes dentists. They go somewhere else, they see someone else, and they see that there's a stain on a restoration. They say, there's decay there. I have to change it. They're not going to tell the patient that they opened it up and there was no decay there. They're just going to be like, well, it was stained. I replaced it. It's all fine now. But that restoration might have been in there for 15 years and didn't have any issues during those 15 years, but had that stain, 2 years in and had no problems until that point in time. So one of the reasons why some restorations get replaced, not all, is because the patient changes dentists and then suddenly the new dentist finds all these problems. So if you can minimize the amount of problems that happen 1, 2, 3, 5, 10 years later, you minimize the chance that the patient will end up getting that restoration replaced. So there's different types of rubber dam. I tend to prefer the non-latex, sort of the ISO-dam these days. There are a lot of patients that can be quite allergic to latex, and sometimes it's hard to remember which ones are the ones that are allergic. So in my dental office these days, I use just non-latex rubber dam. I did use the Nictone rubber dam, which is the latex one, and it's quite good as well. I don't find a huge difference between the two. There are other non-latex brands. I find that they are quite annoying to use, and there are other latex ones that are also equally as annoying to use. The traditional one that we all learn with in dental school, that sort of disgusting green color one, that's the one that I had in dental school. I don't know what it's like in other parts of the world, but it's the one where you basically can see, it's so see-through, you can see the patient's tongue like flicking through underneath. It just kind of looks surreal and weird. It makes everyone hate rubber dam when they graduate, and then they graduate and they start learning proper rubber dam techniques using proper materials, and suddenly they go, oh, there's actually something to this, let's actually use it. And the liquid dams, look, they can help in some very minor circumstances, but mostly they shouldn't be used in day-to-day sort of dentistry. So the fundamental thing with rubber dam is you want to get a good tight seal on using the clamp on the tooth. So you want to have 4 points of contact using your clamp. So the clamp needs to touch the tooth in 4 locations to be nice and stable. If it's not, it's more likely to rock, fall off, and cause other issues. So you either need to use a slightly larger or slightly smaller clamp, depending on the location that you are trying to isolate. Mostly I am doing quadrant-based isolation or I'm doing quadrant-based dentistry in general. So 90% of the time, if I'm isolating an area, I'm going to be isolating from the last tooth in that quadrant to the canine. So it's the second molar to the canine, and I will be using my 27N to isolate. So that will be on the very last tooth. I'll talk how I do my isolation protocol in a minute. I'm not spending a huge amount of time in rubber dam in case anyone's about to fall asleep. And then I will sort of move on from there. If I'm doing maybe some anterior only work, I will use maybe an Ivory 2A, especially if you're doing endodontics or something like that, or if you're only isolating a single tooth, I might do that. If I'm doing work on multiple anterior teeth, such as resin veneers or multiple resin fillings or sort of edge bonding after orthodontics, then I'm going to isolate to the premolars and use an Ivory 2A. I usually use a wing with the premolars because I find that the rubber dam tends to curve a little bit up in those areas because of the way that the arch happens, and it just helps to keep it down and not riding up on the palatal side. I don't like a wing on the molars because it tends to interfere with its placement, because you've got completely forgot my anatomy now. You got patients' cheeks, you got the tongue, you got all those things in the way, and then it can be difficult for some patients to actually accommodate that. I also have the Haloclamp. You used to not be able to get them in Australia for some weird reason. There was someone that would frequently do trips to the UK, and he would actually buy a whole bunch of them from the UK and then come back to Australia and then sort of smuggle them into the country and then sell them to dentists in Australia, like bootlegging rubber dam clamps from the UK. It was a crazy time back in the day, but it's a great clamp if you're ever trying to work on the distal of the last molar, because it reverses round. Those other prongs actually help to keep the dam down, and then you can put a matrix band at the back or do something like that. They also come in single versions that allow you to attach a cotton roll to it, but why you'll use a clamp with a cotton roll and then not put rubber dam is beyond me. But they do make them in case someone ever wanted that. That's always nice. Also, don't be afraid to sort of break the rules a little bit. So this is a premolar clamp, and it was the only thing that I could get to stay stable on this particular tooth. And that's because the furcation was actually starting to be involved. Once you retract everything, there was a bit of furcation involvement. And so I had to stabilize it on one of the roots and then use some Teflon to just keep the rubber dam sealed. It doesn't look like a normal version of that clamp because there's normally these extra little bits that jut out, which I have cut off for unrelated purposes to the isolation of this tooth, just in case someone orders that clamp and then it looks a bit different. I tend not to like those big projections because they kind of get a bit weird in the way sometimes. So they were cut off. When you order a packet of rubber dam, they normally have a stent or a guide in them. The holes are pre-made on that stent to be roughly about 3 millimeters wide. That's the distance between the holes that you need to do to get proper isolation for a standard arch. Now, you do need to vary it if there are any other changes or differences between the standard and what you have there, but 3 millimeters is what you should be aiming for. You can also vary it. So if you've got a standard amount of distance between the teeth, keep the holes the same, like I have got in the middle here. If you've got a bit of extra space, so the teeth have had some bone resorption and there's recession that's occurred, the further down the tooth neck you are, the further away from each other the teeth are, you will need to increase that space, maybe about from 3 millimeters to 4 or 5 millimeters. If there is a tooth missing, you actually need to leave about 1 or 2 holes gap. You can't just leave 1 hole, you have to skip 2. So if you have a first molar that's missing, like in this case, your next hole on your guide should actually be the first premolar, because you need to skip 2 teeth. So if you've got 1 tooth space, you need to skip 2 holes worth of space there. It seems counterintuitive, but once you actually stretch things, that 1 hole space that you think you're going to use actually starts opening up the gaps around the other teeth, and then you lead to more leakage and more issues. Inappropriately placed rubber dam gives you more problems than just not using rubber dam at all. Because what people do is they'll place a rubber dam that's leaking. They don't think it's leaking because they go, I put rubber dam on, everything's perfect. And then what happens is they get moisture on the other side of the rubber dam. They don't realize it. They think it's just water, and then that contaminates things. Whereas if you didn't have a rubber dam on in the first place, your guard is higher and you assume that everything that is water is actually saliva, and then you make sure that you clean it. Whereas if you've got rubber dam on, you let your guard down, which is good if it's done properly. But if it's not done properly and you let your guard down, that's when you get into trouble. You can also buy or 3D print a guide like this, which already has the quadrants made for you. This is the one that I use. It's PacDam is the brand. You can buy them 3D printed and someone sends it to you. You can also download the STL file and 3D print them yourselves. It's completely free. You just go to thingiverse.com and then download PacDam, and then you can make it yourself. And they are quite good. If you have a 3D printer, use it. I did get my lab to also make me a whole bunch when I was running some courses, and the lab just made me a whole bunch, and then I just handed them out at the courses that I was doing as well. So they're pretty good. With the holes for the rubber dam, when you're punching the holes, the largest hole is always for the clamped tooth or the molar that you're working on. The next two holes are just for normal molars. A canine and a premolar is the fourth hole, and then upper anteriors is the second smallest hole, and lower anteriors is the last hole. Most people just do the largest hole for everything and then wonder why their lower anteriors are actually starting to leak everywhere. So vary the hole size based on the size of the tooth that you're working on. A couple of bits of advice with the clamp holders. They all come with kind of a little knob on the end of it, kind of a little ball or a little sort of notch that allows you to grip the clamp. What I find is they're far too engaging when they're completely brand new, and you actually can lock it in there and find it very difficult to remove the forceps and leave the rubber dam clamp behind. So what I do when I get them is I just chop a little bit off so they're not as engaging. And so you're able to disengage it from the clamp when it's on the tooth and be able to take it out, because there's too many times, especially with a lower second molar, that the buccal sort of eminence of the tooth doesn't allow you to move the clamp properly, and then it still is engaged, and then you end up taking the clamp off 14 times, and then you think rubber dam is bad. It's just because you need to adjust the holder. So what I do is I make sure the patient is completely numb on both sides of the tooth. So if you're working on the upper arch, you need to anesthetize the palate and the buccal mucosa. If you don't, and the clamp pinches on something, the patient will flinch, they'll hate it, and then you'll stop using the rubber dam properly. You won't put it in correctly because the patient's hating the experience. And then it's not calming for you, it's not calming for the patient, and then you start to hate the process. Make sure the patient is numb so that you can do things properly. I do like to pre-floss the contact sometimes, because especially if they're very old restorations or amalgams, if they're very rough, then what happens is it tears the rubber dam as you're trying to put it in. In those cases, I may open the cavities up first before placing rubber dam, because I don't want to place the rubber dam, have everything tear, spend all that time placing it, only to have all these holes and have to replace the rubber dam. If the patient is a gagger or they have a really big tongue, you can use what's known as a split dam, where you just cut a straight line through the dam, floss at the front at the end, clean out all the cavities that you need, and then replace it with a normal rubber dam from there. I put the most mesial hole in, I clamp the tooth first, do the most mesial hole, and then floss everything through. Make sure I rock the clamp so it's seated correctly and it doesn't have any open areas around the rubber dam, so I don't have to use that liquid dam. I make sure everything's inverted, I get a photo, and then I move on with my life. That whole process takes about 5 minutes. From numbing the patient to taking the photo is about 5 minutes. And if you're using these accessory clamps like the B4 clamps, they're not designed to hold the rubber dam down. They're designed to invert it and push the rubber dam further down so that you can access a margin or something like that. This is the B4 clamp. They come in all sorts of sizes for all the different shapes of teeth. So molars, anteriors. They're not the most stable clamps. And so what I like to do, especially on a premolar like this one, where you need it to stay exactly where it is. Can you imagine if that clamp like pings off while you're trying to seat your crown? You can use a little bit of flowable or liquid dam just to attach it to a tooth so that it doesn't rock and it doesn't move. So I put a little bit underneath, a little bit above, and then I don't etch or bond the tooth. Usually the friction of the placement and the setting of the composite is enough to hold it in place. If I really need it, I may do a spot bond with one of those self-etching bonds on the enamel, because it's fairly weak when you haven't actually properly etched the tooth. And so I know I can clean it off afterwards. So that is rubber dam in a nutshell. So posterior composites. So the main thing about posterior composites is obviously bonding, and contacts are the main thing. And contacts can obviously be straightforward if you're doing a simple, class 2 restoration, or that can be complex if you're doing a very large 5-surface restoration. So we'll talk a little bit about both, and obviously a little bit about some other factors as well. So there's a reason that you see everyone on Instagram, on Facebook, on all these places, they do the most stunning, beautiful posterior anatomy, and you go, there's no reason for them to do it. You can do a flat composite, it's still going to last, it's still going to work. The reason why they do those kind of restorations is, one, because it makes you feel good as a dentist. It gives you those warm, fuzzy feelings because you've replicated nature. You haven't done something that is, an abomination to nature. You've done something that's meant to be there. If you go to a surgeon to replace a leg and they give you something that's a tentacle, that is completely different than what you were sort of born with. So you're trying to replicate what was missing. The other reason is, if you actually follow the anatomy that is set by the occlusion, you'll find that you end up recreating the exact size and shape of the tooth that was supposed to be there in the first place. The reason why there is a cusp slope of a certain incline, why there is that groove that runs through the center of those teeth, is because the opposing tooth is supposed to fit neatly into that space. If you make something that is just completely flat in this area here, this tooth can't actually fit into it. So it doesn't matter how perfect that is placed. If the opposing tooth can't fit, then you're going to have to start cutting away at this tooth. And I don't know about you, but it's very difficult for me using any sort of burr to actually go back and carve this in, because a point can't actually cut properly at the point. We all know that, so we've all tried to. So then the only other option is using some sort of, football shaped burr or round burr that just ends up gouging out the rest of the tooth. And then you end up with a great big hole like that. And we've all done it. We've all seen someone else's work that looks exactly like that. And it's just, it doesn't look particularly nice. But the problem isn't that it doesn't look nice. It's that it also doesn't function properly. The reason why you have the cusps as they are like this is because when food is placed in this area and the patient bites together, this cusp is forcing the food to go this way. This cusp is forcing the food to go that way. So in the middle, you have a great amount of shear force that is occurring on that tooth. And the shear force that is exerted by the cusps going in opposite directions is built and designed in such a way that it can damage the tooth, damage the food, and break it apart efficiently with as little force and as little sort of masticatory function as possible. What happens if everything is completely flat is you don't end up with the shear force, you end up crushing the food and just sort of mushing it from side to side, which is what happens when patients have poorly made dentures, if they have worn teeth. And one of the things that patients complain about when they have dentures or when they have worn teeth is they're not able to efficiently eat hard foods or chew foods that require a lot of chewing, such as meat or chicken or anything like that, because they actually have to use more of their muscles for longer in order to do the same function as two cusps that are actually going past each other properly. So the cusp inclines are important. We want to try to follow them. So we minimize the amount of occlusal work that the patient needs to do to chew, which means that they're not overexerting their muscles, they're not causing fatigue and not causing all these issues. Now, I'm not saying that if you do a flat occlusal filling, the patient's going to get occlusal fatigue and sort of not be able to chew properly. But what happens is times that one filling by a lifetime of poorly done dentistry over, 28 teeth. And what happens is suddenly the patient is 60 years old and ends up needing a full mouth rehabilitation only because their teeth have worn in uneven ways from uneven fillings being done. And the same goes for the interproximal, the marginal ridges. So when you're creating your marginal ridges, most people end up making something that is very sharp or very far out of the normal. And the patient bites directly here, and then that causes issues. And because of the same principle, it's very hard to then fix that problem using a burr. You end up ditching everything out, even at damaging the adjacent tooth. And then that leads to areas of plaque accumulation, more decay in that area. And then you end up doing this restoration in 1 or 2 years' time. And then the patient has a vicious cycle of damage that's being done, both from their own hand because of the food that they're eating, their lack of brushing, but also from dentistry that hasn't been done to the best standard that is possible. Not saying that everyone does these kind of things, but they do happen to us all. And one of the hardest areas to fix is obviously between a lower canine and a first lower premolar, because it's such a tiny contact. Slightly too high and it causes issues, slightly too low and it's impossible to actually get a contact because of how minute the area is that you're working on. You literally just have this. That is the only area that is possible to have a contact. This can't get a contact, and this down here can't get a contact here. So unless you're very precise with your restorative work, these areas tend to be a very big chance of getting food accumulation, tend to cause a lot of issues with cleaning and things like that. So doing precise work does help. So with anything in dentistry and anything in life, your mindset really determines how you're going to sort of progress through things. I've run hands-on programs, help people with hands-on programs, like I've been saying for nearly 8 years. And what I find is a lot of people will move on from a step before that step is completed for some unknown reason. The amount of people that will anesthetize a tooth and then they will just jump to preparing the tooth, but the patient isn't numb yet. And so they go back and they do some more numbing, and then they'll come back and they'll do some work, and they'll come back and they'll anesthetize, and they go back and forth. Whereas if they just anesthetize the tooth, waited for a period of time, checked that it was anesthetized. So you can use those cotton pellets with the Endofrost, the same thing that you do to do a cold test on a tooth to check vitality, check that the tooth is anesthetized properly, then proceed with a restoration. So you go, I'm just going to check if we're all good to go. Yep, the anesthesia has worked. We're ready to go. So the patient can just relax. They know that they're anesthetized. You know that they're anesthetized, and you're unlikely to get any issues. You turn the patient can watch Netflix, they can do whatever they want, they can meditate, they can close their eyes and go to sleep. And then you can focus on doing your work as predictably as possible. You can put the rubber dam on if you're doing rubber dam, or isolate it, however you're doing it. Make sure it's isolated properly first before you move on to the next step. Because once you move on to the next step, you want to ignore all of the previous things that you've had to do because you assume that they're finished. If you're going back and forth 700 times, then you actually will be slower than if you just did something right, checked, then you moved on. It's just like having a checklist when you're flying a plane or when you're in the army or when you're doing anything like that. You want to make sure that something is correct. You check it and then you verify that you've checked it properly, and then you move on and you ignore that part of the process because it doesn't need to be done again. There's no point in time where you need to etch and then go, have I etched? No, I'm placing the composite. Have I etched? Maybe I'll go back and just etch again, because by that point in time, you have to etch again, you have to rebond, you have to do all the steps again. So make sure you're doing everything and verifying. So there's 1,000 billion quadrillion different bonding systems out there. And I'm sure by the time that you see this lecture, there will be 400 more that are on the market. And every single one of them is the best bonding system ever created by mankind. As long as you're following the manufacturer's instructions and you're using the bonding system correctly and it's working for you, use it. The worst possible time that you can have as a dentist is when you change bonding systems. Because what will happen is you will just do the same thing that you used to do on the old bonding system, but it'll be completely different for the new bonding system. I've had bonding systems where one, you need to scrub it on there for 30 seconds and then lightly air dry it for another 20 seconds. And then other bonding systems is you touch it on the tooth, you leave it for 5 seconds, and you blast it with air for 5 seconds. Any more or any less will completely void the bonding that you've done and ruin the whole thing. So make sure you follow the instructions of the manufacturer. Some bonding systems will work better in your hands compared to my hands. So if I'm using something and recommending something, it's because it works for me. If you have something and it works for you, just use what you have. Unless something is not working with what you have, then you can start exploring other ideas. Okay. If what you're using has been working for 20 years, there's no need to change it unless the manufacturer makes an error on a batch and ruins the whole experience for everyone, or it's not sold anymore, or you're actually starting to realize that you have problems. One of the things that people don't realize is patients will get sensitivity after your, composites or any restoration, but they don't realize it because they don't actually ask their patients. So one of the things that some people do is they'll call the patient up, or they'll get their team to call them up the next day and say, how's everything feeling? Is everything feeling okay? Is it too high? Does it feel sensitive? And if you do that and the patient's like, everything's fine, there are no issues, then everything's fine and no issues. But if you wait till 6 months later to ask the patient how it is, I guarantee you they will tell you something like, it took a couple of months to settle, but it was fine. It was a little bit high, but it evened out in the end. And you're learning all of those bits and pieces. And it's not because you're a bad dentist. You just didn't know that you were having these issues until 6 months later. And it's very hard to rectify those problems when it's 6 months between when you find out about a problem. So just bear that in mind about your bonding system. It may not be as perfect as you think it is. So they have done many, many, many studies on bonding systems. One of the most studied things in dentistry, other than occlusion and ceramics. So the hybrid layer that is formed between your self-etch adhesive system, so when the etch is incorporated into the bonding system, so it's an etch prime bond, a single bottle system, versus your separate etch and rinse systems. Anything that is self-etch will have a weaker bond to enamel compared to a separate etch, rinse, and then place a bonding system on there. The micro tag formation with a self-etching system isn't as deep or as deeply penetrating as a proper etching system. So even if you're using a self-etching bond, you still need to do selective etching of the enamel in order to increase that hybrid layer formation. The other problem that you find is with self-etching systems, there's going to be an inefficient removal of the smear layer. So if you've been doing a lot of cleaning of if there's been a lot of stuff in the cavity, a lot of decay, you've been sandblasting, and you haven't cleaned that out properly, and then you use a self-etching system, all of those bits of debris that have been shoved into the canals are actually incorporated into the hybrid layer. So where you think you've actually put resin into the dentinal tubules and into the micro tags that you formed into the enamel. It's actually being blocked by debris, by aluminium oxide, by various different things. So using an etch will actually clean a lot of that out and then allow you to then use your self-etching adhesive system to the best of its ability. If you have a look at this case, this is a Maryland bridge and veneer case that is completely unrelated to what we're trying to teach with posterior composites, but it teaches one fundamental thing. This patient came in and I said, wow, your teeth look, really clean. She goes, thanks. I just brushed them. I spent extra long brushing them because I knew that I was getting my teeth done today. I was like, that's awesome. I'm going to place some plaque disclosing solution on them anyway. So she came in, they look pretty clean. She says they're pretty clean. However, when you actually put plaque disclosing solution on them, you can see these areas. Now, ignore the areas around the gum line. We're never bonding onto the gingiva, so it doesn't matter if they change color. But you can see all of these areas where there is actually plaque that is on these teeth. So if we are going to be placing any restorative work on any tooth structure, we want to make sure that we're actually cleaning the tooth structure correctly so that we can then etch it properly, so that we can then bond properly. Ideally, you're going to be using a sandblaster in order to clean things out, whether it is something like the AquaCare or a RondoFlex or a Danville microetcher or anything like that uses aluminium oxide, bicarb soda, whatever your powder of choice is for just general cleaning and microetching, then you need to use it to remove the smear layer, remove the pedicle, remove the biofilm that's on the teeth, because there's thousands of studies that have been done that suggest that the etch cannot penetrate through a thick biofilm to actually then penetrate the enamel. It needs to be mechanically removed. Now, if you don't have a sandblaster, the best thing is just get some pumice and a Profi cup and then just go over all the teeth and do that. That is going to be the best thing that you can do to clean the teeth. And if you're doing it on the occlusal, then I would generally find a Profi brush will work better to get into all the little grooves compared to a Profi cup. So what is my actual bonding protocol? What do I do? And it's the same for posteriors. It's the same for anteriors. So I will clean out and open up the cavity initially. I will see where the lesion extends. I will then go a little bit deeper as I need to. With a high speed, I use electric handpieces for the red band, electric handpieces for all of my work, not the air turbine. One, they're a bit too loud and annoying, and also they're not very efficient at cutting things. So I like torque, so I'm going to use something that's very high torque. Then get to where the decay is. I clean everything out with a slow speed fur. Okay, we want to make sure that everything is clean and there's no decay left behind. We're talking about very small routine fillings here. Then I clean it with aluminium oxide. I'm normally using 27 micron aluminium oxide. I then will do any selective etching that I need to do. So I selectively etch, and then I'll leave it on for 20 seconds. Generally, by the time that you've actually put the etch on and sort of, put one thing to one side and then come back, it's been about 20 seconds. And then I will rinse everything. Notice that I leave the dentine moist. I'm not getting it to be bone dry. Depending on your bonding system, it is either going to have a acetone or an alcohol in it that will help displace the water that is on the dentine and in the dentinal tubules. If things are completely dry, what tends to happen is the collagen fibrils in the dentine will collapse and actually close over those dentinal tubules and not allow a deep penetration of the bond into them, causing issues with sensitivity and sometimes even pain on biting because there's been trapped water or trapped air underneath the filling. And then every time the patient bites, they can get pain. So if the patient comes back, a day later and says, every time I bite, it feels painful, and you know that the occlusion is perfect because everyone will always check the occlusion first and adjust that first and say, come back another day. And they say, no, it still hurts. Just take the restoration out. It's a bonding issue. There's been some trapped air, some trapped moisture, and you just need to replace everything, and everything's generally fine after that. So leave everything damp. I make sure it's not bone dry. If you do dry it, just rehydrate it either with a cotton pellet with some water or just put some water from the triple syringe or triple X back on there. I use Scotchbond Universal Plus, I think it's called now, or Scotchbond Ultimate, whatever the branding is called now. It's the one that goes with the 3M Relax Ultimate, I think is the one. That's I hated the previous iteration, with a passion. I actually used it and moved completely away from it for 5 years. And then they came back and they changed the formulation. It actually is quite wonderful to use. I've been using it for ever since they brought it out. So I scrub that on for a good 20 seconds and then I thin it out and then I set it. I will then place a radio opaque liner, which in this case is just Genial Flow X at the base of my cavity, so I know where the cavity is. I then will use paste composite and either flowable, that's moving far too quickly for my liking, but either place paste composites or so paste composite everywhere on the dentine floor up to the enamel just below the level of the enamel. Now, obviously, if it's a very deep cavity, I'm going to be doing it in a couple of increments, but I do the dentine bit first, and then my final increments, I can do the actual occlusal anatomy, follow the cusp inclines. I have experimented, Mindaugas out of Lithuania does, with using the Genial Universal Injectable, which does work quite nicely, especially when you're trying to do microanatomy. You can see it looks quite nice here. I did sort of stuff it up a little bit in this area here, but here it is quite nice with the extra lobes and anatomy, which always look great when you're trying to do a lecture. Some of this is for me, some of this is for you, and a lot of this is for the patient as well. But what we care about is that the occlusion is nowhere near the composite, and I didn't have to do any adjustment afterwards, which is great. It makes your day run amazingly well, especially when patients have it done like that and they go, wow, no adjustment. It's like, well, thank you, I know what I'm doing. And then you can sort of move on from there. Gives them a smile, you can smile. So what happens when it's not something that's really small? When it's something that is particularly large? So there is a systematic approach that was developed by Pascal Magnier and David Lehman, which is actually quite a great system and what I do use quite a lot. I have adapted it a little bit for my protocol and how the materials that I use, but it's essentially the exact same method. So if something is not close to the pulp chamber, you just do your restoration as per normal. So you take things apart, you do all your bonding, you fill as you normally would. If something is close to the pulp chamber, what you do is you remove everything around the periphery perfectly. So you want the periphery about 2 to 3 millimeters around the periphery to be perfectly clean. Anything that is very close to the pulp, you remove all the infected dentine and you leave the affected dentine. This is on a tooth that you've tested before you've anesthetized the patient and you know they are asymptomatic, they have a vital pulp response, and they have no periapical lesion on their tooth. So these are cases that it's going to be a fit and healthy patient with a fit and healthy tooth, and you're giving the tooth a chance to lay down tertiary dentine and wall itself off from that decay so that you can minimize the chance of needing a root canal. And since I started doing this, the amount of root canals I've had to do have dropped very dramatically. And it's because you actually do really good bonding around the periphery and you seal off the food source for that bacteria. You basically entomb it. And you're doing this with a patient's permission, of course, because there are some patients that travel very long distances to see me, or I've got patients that work in oil rigs in the middle of the ocean. And for them to get a toothache to fly back to the mainland is like a 15-hour helicopter ride. And so it's very expensive for them to have a dental problem. So for those patients, we don't do, oh, let's just see how we go. And they're more likely to be, hey, let's just do a root canal because we know that this is going to turn into one kind of patients. The little old lady that lives down the road or the student that lives next door to you, they're going to be okay. If they wake up tomorrow and they've got a little bit of a toothache, they can come back in and get something done. Someone that travels, from the other side of the country to see you, they may not be as forgiving if they get a problem. And then I do an indirect pulp cap with resin. I don't use something that's going to irritate the pulp. We want to keep everything nice and calm. I don't use letter mix. I don't use calcium hydroxide, cement over the top. We want to use a indirect pulp cap with a resin to keep everything nice and sealed. The reason why I do that first and not incorporate that in the rest of the restoration is because it's actually a weaker bond to areas with affected dentine. The presence of the bacterial toxins influence the bonding, and so it's a bit weaker. So I want to do that bit first, extend it out, and then do my other bonding over the top. So I'm not causing any shrinkage stress on that affected area. If it's non-vital, if it's large, if there's irreversible signs of bias, or as we were saying, if the patient is one of those patients they're not going to be very forgiving if they get a problem, then you're more likely to go down either the elective or a forced root canal pathway, and you're going to extirpate the tooth and do whatever work that you need to do from there. So obviously you may not remove all of that tooth structure, but then you do whatever you need to do. So that's the protocol. It's summarized from that journal article, but that's a very good journal article if you can get your hands on it to read through. It's got the whole process there. You test the vitality, you anesthetize and isolate properly with rubber dam, you assess the lesion. They use caries detecting dye. I don't personally like to use it for various different reasons. You start from the outside, work your way in. Once you have 1 to 3 millimeters of dentine, bigger tooth, 3 millimeters of dentine, smaller tooth, 1 to 2 millimeters. If you've got a lower incisor, 3 millimeters is basically sometimes the distance from one side to the other. So just be mindful of the amount of tooth structure that you are cleaning. slowly work your way inwards. You clean it with a chlorhexidine, a pure chlorhexidine, not just mouthwash that you have in the back cupboard, a pure chlorhexidine for a cavity scrub to clean and isolate and inactivate the MMPs and try to inactivate the bacteria. Then you sandblast and you bond as you normally would. A couple little tips when you're doing your posterior composites before we move on to matrix bands. When you're cutting your cavities, either use something like a wedge guard, a fender wedge, a Toffelmeier matrix band with a wooden wedge shoved in there, just so you can avoid damaging the adjacent tooth, or leave a little lip of composite or enamel there that you can then break off once you get to these edges here. The last thing you want to do is damage the adjacent tooth, and then a year or a couple of years later, the patient gets decayed there, and then you sit there wondering, did I cause this problem, or did the patient just not clean properly around the restoration? If you've done your restoration correctly, they don't need to clean it any differently than a normal tooth. But patients, unfortunately, don't clean around their normal tooth properly. That's why they ended up with a problem in the first place. So we can be a bit forgiving, but we don't want to introduce new problems to the patient. So a little bit about C factor. So when you've got a cavity that is very sort of thin and narrow and it's got a lot of walls, and you just sort of plonk some composite or some composite in and then you set it, it's going to shrink towards the strongest bonded surface, which is generally the enamel. Okay, it's going to shrink away from the weakest area, not because it's shrinkage happens inwardly, but what happens is it's actually tightly holding on to one wall and the other wall is a bit weaker. A lot of people think, unfortunately, that it moves towards the light source, like it's being called up to heaven towards the heavenly light that it sees. It's unfortunately not true. I mean, if you want, you can place some composite on the table and then try to set it with the curing light and see if it starts levitating towards the curing light. It won't. It just shrinks away from the weakest bonded surface. So obviously bulk composites and some newer composites have less of an issue with shrinkage just because of the way that they've designed the composites, but still it's something to bear in mind as you're doing things. So every composite is going to shrink. It's just some will shrink more than others. Some brands have a tendency to shrink a lot more than others. So what we do to get around that is we tend to, and you can see here, it's just sort of shrunk in that corner. And what happens as it shrinks is it pulls and breaks that bond and breaks those micro tag formations, breaks that hybrid layer that's been formed. And then there is a water gap in that area. And because this is a living system, some moisture and fluid will get in there. And what happens is as the patient bites, there's going to be hydrostatic pressure that causes that fluid to move back into the tubules. And then that odontoblastic process that we all learned about back when we were in dental school that we've completely forgotten about actually then starts going ouch, because it is the change in the fluid dynamics in the dentinal tubule that causes the odontoblastic process to give us that pain response. So heat causes the water to expand, cold causes the water to contract, and that causes that pain response. The same thing happens if you're biting on it and there is space and the water can move in and out. It causes that same pressure. So we build it up in 1,000 different 2 millimeter increments. And that's generally because obviously the curing lights don't cure as deep as 2 millimeters. There's studies that show that even if your curing light says it can do 8 millimeters, it's only really doing 2 millimeters. It does depend on the translucency of the composite that you're using and many other factors. So in general, it's about 2 millimeters. A lot of the times we tend to break the rules. I know a lot of people who sit there and measure 2 millimeters with a probe and just make sure that it's done like that, but then they'll take 400 hours to do their composite restorations. I know other people that will do one cure at the base and then do curing on the top, which is what I prefer to do, and then they don't have issues as often. If you, however, don't make your cavity as narrow as humanly possible, and that doesn't mean that if the filling is really small, you make it really big just so you have a nice big cavity. It's just make sure that everything is more flowing. You don't have all these static walls. You're not using a burr that has a right angle at its base. You're using a chamfer, a rounded burr. You don't have a single wall. You don't have multiple walls. You just have one flowing wall. You mitigate a lot of those issues because everything is equally as distributed out and you have a lot less shrinkage stress that is happening on those teeth. When we're doing composites on the buccal surface of a tooth, we don't sit there and do individual little increments most often. We tend to do a single increment and then we set it. We're not worried about shrinkage stress in those cases because it essentially is a single wall. When you're doing a veneer on a tooth, you're not going to be doing it in micro little layers of 2 increments because it's a thin single wall. So if you're converting your cavities into a more flowing design, you're not going to have as big an issue with your shrinkage stress from there. So if you build up your base in whatever material you're going to be using, and then you can do your occlusal anatomy with your composites at the top in the small increments so that you can design things. So if you're doing something like this, like a small cavity on a posterior tooth, you remove everything that's not supposed to be there, you clean it all out, You sandblast it. The sandblasting tends to bevel the enamel ring. I don't on the occlusal go there and bevel the enamel as per normal. I then just let the sandblasting do it. I use some chromatic dentine because I felt fancy that day. And then I do the dentine, and then I do 3 increments of the enamel area there, there, and there. And then I put some tint because I was taking photos, so why not? Will the patient die if I don't put tint? No, they will survive. It just looks nice on photos. And then things work. The same thing as if it's slightly larger, you just open things out. You can see how it's more flowing. It's not that tight little amalgam prep that we did when we were in dental school. It flows out. It all works. It all fits with the occlusal anatomy. It's not built out. You can see the difference between this tooth here. Neither of these teeth are in occlusion in this central area. So the patient's bite is such that both of these teeth are out of occlusion, the fillings that are there. But if you actually see, I've probably exaggerated this a bit much, but you can actually see that this tooth and this tooth are both on the same patient. They both can work, but I would rather have something like that in my mouth than something like that. But it does depend on the individual circumstances. Even something slightly larger than that. So a lot of people argue that this may need something as an indirect because there's lots of cracks going in lots of different directions. I argue that to the patient as well. However, his budget didn't extend to that. So we just did the best composite we could. And I believe it is still there. It was also one of those fact-finding missions that you do sometimes with big restoration where you open it up to see what's underneath so that you can take a photo and show the patient, say, hey, remember when I told you that there was a big crack in this tooth? Here's a photo showing you that there's a big crack in this tooth. It's like, I've been doing this for a few years. I know what I'm looking at. Now you definitely need a crown. And then, they come back 12 years later and tell you, remember that tooth you said needed a crown? It still was there. It's like, shouldn't have done such a good job on my composite. Now they'll never get the crown. When you're doing interproximal restorations, the same thought process applies. You don't want to do a cavity that is really tiny. You want to extend things out. So one, you're not causing any shrinkage stress issues, but also when the patient is brushing their teeth, their toothbrush bristles are going to extend probably only about as far as that, because as much as Colgate and Oral-B want to make products that will get interproximal to here with the one hair toothbrush bristle of their new fancy toothbrush, patients are doing weird movements with their toothbrush, 1,000 oscillations a second if they're even brushing their teeth. And so it's very unlikely that a toothbrush is ever going to get into this area. And we all know that our patients don't floss anywhere near as frequently as, once a month, let alone once a day. So we want to put the margins of our restoration in an area that's easily cleanable. We don't want to do a little amalgam prep that's like this. We want to extend things out. Now, that doesn't mean that you extend it this way as well. We're just talking about extending it this way. You can see how this cavity is not very deep at all. We've actually just extended it this way, and there was actually a little bit of decay in this area. You can see the cracks. Usually where there's a crack, there's decay. That's why it's had to be extended that far deep. But normally I would just bevel the enamel out here. So you get some beveling of the enamel outwards so that the margin of the restoration is out of the interproximal contact area. You don't want the margin to be within the interproximal area. So with interproximal restorations, you start with your prep, just like you normally do. We'll pretend that these are nice flowing designs here. It's a bit hard on Keynote to make it super flowing and wonderful. You place your wedge in, you place your matrix band in, and then you'll do a marginal ridge or interproximal area of composite in there. You place it in, you use a microbrush to push it against the matrix band and make it all nice and clean and flush, and put a little bit of drop of flowable down to make sure everything is sealed, make sure you're using heated composite so that everything flows nicely. You're using your Explorer so that you can follow the natural anatomy and make sure that this marginal ridge is no higher than the adjacent marginal ridge. You're using the adjacent tooth as a guide. There's no point putting a marginal ridge up here if the adjacent one's all the way down here. Follow the anatomy that's been given to you. And then once you've set that, you then place another increment, especially if it's deep, and then another increment, and then you can start doing your occlusal anatomy from there. So we want the prep design to not have any sharp edges. We don't want to have an amalgam style prep. We're not placing amalgam. We don't want amalgam preps. We don't want unsupported enamel, because what can happen is the shrinkage stress can actually crack that enamel and end up with an area that's going to accumulate staining, decay, or issues. We also don't want to have unsupported enamel, because during function, what can happen is it can crack under load because it's actually not supported by the composite, especially around the periphery, especially if you have those little wings of, I was going to say wings of composite, but wings of enamel that just, if you're using if you're just using a chamfer burr and you stop it interproximal, you get these little wings, kind of like a J-prep margin, but on the edges of your composite. All you need to do is get a flame burr and just sort of lip that bit off, and then it becomes nice and even there. and then you want a nice flowing design. These are the burrs that I use 95, 99% of the time. It's in every one of my lectures. You can take a screenshot if you want, or it's in pretty much every lecture that I normally run as well. We don't want to use the smallest possible burr that's in your burr caddy to do any of these restorations. The amount of times I've seen dentists, because a lot of people take videos of their work now and they put it up on Instagram, and they will use a small round burr to open up a cavity like this. I have seen it. It is infuriating because we all know that the cavity extends all the way to this blue area. There is no point trying to explore this middle area here in the middle because we know that all of this is unsupported enamel. The supported enamel is all the way here in this color over here. All you need to do is clean it all out, get a big burr, get rid of anything that is not supposed to be there. Don't use a small one. Use one of the big burrs, clean it all out. We can't do a movement like that in the mouth because obviously the patient's head is in the way, their throat is in the way. So you do a movement like that, you change your burr over, clean the other side out. There's a lot more cleaning that needs to be done. Yes, this patient needs a root canal. It's unrelated. You just need to clean everything out. Don't use a tiny burr. With matrix selection, check your bite wings before you actually tell the patient that you need a restoration because, and you'll understand why in a minute, if there's between 0 to 2 millimeters of space, and this is space between the neck of one tooth and the neck of the adjacent tooth that you're working on, okay? This is not space between the enamel. This is all the way down in the cervical area. So space between the cervical area. Anything between 0 to 2 millimeters. And if your x-ray is not calibrated and you can't actually measure on it, then it's an arbitrary sort of 0 to 2 millimeters, especially if you're using film x-rays. And if you're sort of blowing the x-ray up to a big size, you can't just use a ruler off your desk and sort of go like that. You either have to use the one that's built into the software or just sort of look and guess. 0 to 2 millimeters, you can use pretty much anything and it's going to be fine. 2 to 3 millimeters, you can use BioClear, you can use any form of other matrix, but bear in mind when you get to that 2 to 3 millimeter mark, there's only those extra wide BioClear ones that will actually do the work that is required. If there's more than, so the sort of the extra, they make the extra sort of depth ones for posteriors. If you have more than 3 millimeters between the neck of the tooth, I know I said the neck and the neck of the tooth, but it's the neck of the cervical of one tooth and the contact point, that you're trying to create. If it's between 0 to 2 millimeters, anything will work. 2 to 3 millimeters, there are some specific BioClear ones that will work. You can get it to work with other ones, but you will struggle a little bit. Anything that is more than 3 millimeters of distance between where you want the restorative work to start from and the contact point, you actually need an indirect. So whether it's an indirect composite, whether it's a ceramic, whether it's gold, it has to be made outside of the mouth. It's very difficult to actually get the composite to do what you want it to do. And that's why you need to do it before you tell the patient, because if you get to the day and you find out that, hey, this is 5 millimeters between this tooth and the contact I need to create, I don't have a matrix to do it, the patient's going to look at you very funny if you tell them then that they need a crown, not at the time where you were supposed to be diagnosing and planning it. Make sure your matrix band is about 1 millimeter higher than the marginal ridge that you're trying to create, and that's because you want space to be able to create it. And it acts as a guide. Don't make it too low because obviously you can't create it. Don't make it too high because then the contact point isn't in the right place. Matrix bands are pre-curved by the manufacturer to be in the ideal place. So make sure you are copying what is there. Don't burnish your matrix bands because you're ruining the work that the manufacturer did to do things. The thickness of the matrix band gives you an indication of how easily it is deformed. A thinner matrix band obviously doesn't need as much space and separation to actually create a good contact because the separation of the teeth is created by the wedge and the separating ring. So a thinner matrix band doesn't need as much separation to create a good contact, but they're very easy to deform. Think of the original V-ring ones, the old Garrison ones. You kind of put it in and it just crumbles if you put it in the wrong way. They're very good if you get it right the first time. If it touches anything and bends, you might as well just throw it out and start again. It's like trying to put a GP point or a paper point into a canal and then it curls and it hits something and then you're like, well, this is completely useless. Like you can't straighten it and then it's very difficult. A thicker matrix band, like, those 50 micron thick Tor VM ones, they will withstand, a bomb blast basically going off and not deform. But you need to basically hammer a wooden wedge between the teeth in order to separate the teeth enough to actually not create an open contact when you take that out because it's so thick. So the thicker the matrix, the easier it is to place, but the harder it is to actually separate the teeth. And wedges matter. It also matters what side you put the wedge in. You put the fatter side of the wedge where the fatter embrasure is, and the thinner side of the wedge comes out where the thinner part of the embrasure is. There's 1,000 different types of matrix band out there. I'm not going to go through them all. Just know that if you're keeping things really, really tiny, you're not going to get good contacts. If you open things up, so the previous, you can see these small little restorations that were done. The patient hasn't been able to clean things. The patient doesn't clean things normally, as you can see, but they also are suffering from poor quality dentistry. You can see the fissure sealant that was done here. It probably extended everywhere else at some point, but it fell out. The patient probably needed an occlusal restoration, not a fissure sealant in this particular case. And so everything needed to be opened up. And this is the size of the filling that was done. This is the size of the cavity that I've then created to solve the problem caused by the small filling. So the dentist was trying to be conservative, but a couple of years later, they ended up with a non-conservative problem that I then needed to fix. So that's the size of the cavity that exists now. If I was doing the original restoration, that's probably the size of the cavity that I would have done. And you can see that it extends a little bit further into the enamel, but it keeps things a lot easier for the patient to clean and last a lot longer. And then you're placing your matrix bands, you're placing your separating ring, and you're restoring one contact at a time. You're not creating multiple points of failure. You solve one problem at a time, then move on to the next. Another contact, move on to the next. And you keep doing that until everything's solved. Not the best work there, but it does work. It's the same concept with other teeth. So this is like a BioClear kind of system, and you just place the composite in there, and then you can fill things up. And don't be afraid to use different matrix bands on the same patient, or different matrix bands on different sides of the tooth. Sometimes I'll use 3 or 4 different types of matrix bands. This is a transparent premolar matrix that's designed to go in a Tofflemire holder. However, I don't tend to use them in the Tofflemire holder. I cut them and just use them as like a BioClear kind of substitute sometimes. And it's perfectly fine to use a different type of wedge with a different type of matrix band and a different type of ring system. So if you've got a favorite ring system, you can use that with different types of matrix bands. They are interchangeable, even if the companies don't like you doing that. Make sure that the wedge is tight and hitting the matrix band. You want it to actually be touching the matrix band and holding it against the tooth. If you need to, you can use some Teflon just to give a bit of extra support on one side or the other. When you are placing your matrix bands, like I said, they are pre-curved. Make sure the center of that matrix band, which has the maximum curvature built into it, is facing where you want your contact to be. You want it to be where the manufacturer wants the contact to be, not sort of sitting all the way over here. And then you try to curve this bit here by burnishing it. This is where the contact is on the matrix band. Make sure that's where you want the contact to be. Once you've made one contact, you can then adjust it. So you can polish it if you need to, straighten it up if it's a little bit overextended, and then place the other matrix band and copy the exact same thing. There's no point having one contact with the matrix band here and then the other one all the way over here and then trying to burnish this to actually fit here. Just rotate your matrix band around until the middle of it is exactly where you want it to be. So make your life easier, let the manufacturer do the job. And then needs a little bit of cleanup there, but that's all sort of finished there. If you've got a deep subgingival margin, if you can seal it, so if you place rubber dam, Teflon, isolate it, however you're going to do it, you can fill it. So if you can't isolate it, you can't fill it, you can extract the tooth. You can tell the patient, hey, I'm going to try. If I can't do it, I'm just going to abort. Remove any gum that's in the way. You can use a laser, you can use a gingival trimming burr, you can use a scalpel, electrosurgery, whatever system you've got, you just got to get the gum out of the way. Book longer than you actually think you need because they actually take a lot longer than you think they actually will take. Sometimes you don't get the right matrix the first time. This is a very deep case. Trim away the gum, get to where things are, extend your rubber dam. Like we said, the further apical you go, the more space there is between teeth. So you will need to put more space between the rubber dam holes. And then isolate everything, remove any decay, isolate again if you need to. Try as many matrices as you need. This was a clear strip that was all I had that would actually fit this tooth. Is a clear strip that you use on anterior teeth to do fillings on anterior teeth. I cut it and managed to get it to fit on the top of my holder, and that was the only thing that was actually working in this particular case. So don't be afraid to think outside of the box with deep cases. Fill it, do one restoration, then do the other. I probably should have built out these walls a little bit more before